And next, I'd like to invite our president, uh, who has graced the occasion by coming here and delivering a talk, Dr. LALIT VERMA, who doesn't need any introduction. We'll be talking in one of the most common situations faced by anterior segment surgeon, that is posterior capsular rent. Now, many of you debate whether posterior capsular rent should be managed from the anterior segment or from the posterior segment. So he'll highlight which are the best techniques of managing posterior segment surgeons, telling us the advantages and disadvantages of the technique from anterior segment and posterior segment. Dr. LALIT VERMA.
नहीं कुछ ऑफ नहीं है अभी हो ही सकता हूँ.
Actually, this concept was first propagated by Dr. Abhay Vasavada, but how we landed up into a situation with this technique is we had an injury, needle stick injury, which caused an traumatic cataract, and there was a vertical slit in the anterior capsule. Our anterior segment surgeon, Bharat, was operating that day. Our anterior segment surgeon said that I'll remove this. The moment he entered into the anterior segment, he realized that there is a vitreous mixed with cortex. So he was not able to perform his routine surgery. Then we went from behind, and you will see in the coming videos how this surgery was managed, and the result was excellent, and patient recovered with well-centered lens, no cataract, with 6/6 vision.
Thank you, Avnindra, and thank you, Ritesh, for this very apt course, holding hands. You see, I had coined this term APPA. Sometimes anterior segment surgeon holds hands, sometimes posterior segment surgeon holds hands of the other party. But by and large, the posterior segment surgeons are called for whenever there is PCR or the vision is not getting fulfilled. And all the topics here are when posterior segment surgeon comes to the rescue of anterior segment. No financial disclosures here, and this slide is mandatory for all of us to put a second slide. So PCR does happen with everybody. Even the greatest of the surgeons will have sometimes PCR. And what I believe is it's the overconfidence generally which leads to PCR, or when the surgeon is in a hurry, and or at the fag end of the case, or he is nervous because of VIP patient. Then these are the situations where I have seen the anterior segment surgeons sometimes sweating also. So issue is not PCR, even if it happens, but issue is how, in that situation of panic, what is the approach of the anterior segment surgeon, how it should be managed. So I'll show one or two videos here. So this situation is there where PCR has happened, and you see what the surgeon is doing. This section has been enlarged, and you do a vitrectomy with, in the left side, some infusion, and in the main hand, right hand, you would keep doing vitrectomy. I'm not sure whether the vitreous is getting cut or not, but the movement of the cutter is definitely there. Whether vitreous is getting engaged here or not, it's not very sure. Because this is a blind kind of vitrectomy. You are not seeing what you are cutting. Sometimes if it is formed, you may, but generally it's a blind vitrectomy. So you see another situation here. Here again, PCR has happened. You could have done this same vitrectomy, but surgeon is wise enough, he injects tricot. Advantage of tricot is that it gets adsorbed onto the vitreous fibrils and makes the invisible thing visible. So you are precise in your approach, that you will approach this white colored, this vitreous. You see this fibril here, which could not have been picked up in case you are doing a blind, unstained kind of vitrectomy. So this is more definitive, and this is what I would advocate, or all our group here does this. So you inject some crystal tricot, wait for some time and do this tricot assisted vitrectomy if you are anterior segment surgeon and not used to going from pars plana or hesitate to go from pars plana. So what are the do's if VR support is not at hand? Because I see most of the anterior segment surgeons are hesitating to enter from the pars plana area. So do a good vitrectomy, but it should be a tricot assisted kind of vitrectomy. And aim should be that nice round pupil should be formed at that time. And how to do it? Do not pull the vitreous too much. Suction should not be very high. And it should be a good cutter. Good cutter means it's not a cutter you have not used for ages and ages. Suddenly you start, in a panic situation, any cutter. So it should be a good, maybe fresh cutter. And handled, the infusions should be slow. And since you are going from the anterior segment, it is possible that you may damage whatever capsule or rexes you have. So you should try to leave behind, because patient rehabilitation also is very, very important. And leave behind as much capsule or rexes, because we can support the sulcus fixated lens here. And do not dive into the vitreous. Your plane of operation should be in and around the iris only. And movement should not be like, cutter is like this. Cutter should be like this, horizontally placed. So you can do it. The other question very frequently asked is, after doing this, you can easily insert this lens. This situation I'm talking when the VR support is not at hand and you are alone doing it, and then put suture there. Suture is important at that time. So these couple of things, if anterior segment surgeon follows, I think the posterior segment complications can be avoided, CME or even detachments or traction onto the vitreous. So this should be followed by all anterior segment surgeons if they have PCR and if the retina support is not at hand. And this, I think, tricot does help in doing a specific job, doing a job under visualization. So this should be learned. So in the event of crisis, so these photographs which I have taken are actually patients who had eventful surgery in the form of PCR. Some will have detachment, some will have corneal edema, some will have CMEs. So other thing which we say, do not do this fishing kind of job if the nucleus is there. So respect the vitreous. If you want your patients to respect you, you have to respect the vitreous. The problem is it's not visible, so therefore you put tricot. So as I said, why chromo or colored kind of vitrectomy? Because clear vitreous is difficult to see, and triamcinolone gets absorbed and makes the invisible thing to easily visualization, and thus facilitates precise job, complete job, and time taken is also less. And very important is reduces the chances of these complications. The other thing is pars plana approach. Because the reason of pars plana approach is that if you are doing this kind of vitrectomy, even if you are doing tricot assisted vitrectomy, if the PCR is liable to get enlarged, as was shown in this YouTube video, suppose, let me come to the video state. Suppose this is the, posterior capsule and this is the rent. Red is the vitreous. And if it is, done from behind, so this vitreous is collapsing down. This is, somebody is pulling the vitreous down from the pars plana. And whereas if you do from anterior segment, that is pull the anterior segment vitreous, this is liable to get enlarged. So that is the reason I think why we do not advocate. Let me exemplify with this case with AG was referring. This was a patient who had this traumatic cataract, and we knew it is possible that patient may have, PCR or pre-existing rent there. So this was the beginning surgery, the rexis done, aspiration being tried, but since the vitreous and lens matter was admixed, it was not coming out. So that is when the posterior segment surgeon intervenes, makes all these ports, goes from pars plana 3.5 millimeter behind, makes all these 3 ports, and be very, very careful that you do not damage the capsular support, because that will support the lens, and take out this cortical matter. Use a mixture of both cutting suction and only suction sometimes, and remove this matter, which should not take much time. Cutting is also important, because otherwise you will put a drag onto the vitreous. if only suction is used very commonly.
Since most of the anterior segment surgeons will not have access to the posterior distinct, is it possible that we go deep into the from the rent and then start?
That is known as far weight kind of technique. Far weight is technique described by Amar Agarwal, where he goes from the anterior segment limbus approach, goes deep, which is not advocated because you will have a lot of corneal complications and precise job cannot be done. You see, we do not advocate that you dive deep into it. He sometimes will go deep into it and take out the nucleus matter also. Yes, Dr. Gerard.
I have one question and one comment.
Yeah.
One question, if you're doing it from anteriorly and you put the tricord in, if you leave any in, will it still absorb?
Yeah.
later on?
There's no issue. Tricot can be easily left behind few crystals. In
It will absorb.
fact, sometimes deliberately we do it. We leave behind because a steroid inside the eye, unless you are unlucky for endophthalmitis, but by and large, this will aid in controlling inflammation and reduce the chances of CME also.
And I see you didn't.
So in all retinal surgeries also, once we stain the posterior hyaloid, we deliberately leave behind some crystals of tricot.
And I see that you didn't use tricord when you did from the PARS PLANA.
Not required.
Okay, next. For the anterior segment surgeons, I see you put trocars in, and a lot of anterior segment surgeons are not adept at putting in a trocar. My comment is this: you could just make a penetration with a small blade and put your phaco tip in there, and perhaps have the inflow from your original limbal incision, inflow through, keep the bottle low, inflow through the incision, and just put your phaco probe in without the trocar.
All these combinations are possible. But last message I will just share with you. Then I think we'll discuss on this comment.
It won't be
Yeah.
a phaco probe that you'll put.
Yeah.
It will be a vitrector that you put.
Vitrector only, because phaco probe the dimensions and all, because we want thinner spots.
It will not cut the vitreous.
Yeah. So I'll just finish. Let me finish. This is a small video only. So you see how the surgeon is, taking care of this cortical matter and leaving behind enough capsular support. So now that this job is done, so this is the message we wanted to convey, that PCR management from the limbus route, the possibility of rent extension, possibility of traction onto the retina and the macula, and possibility of leaving behind residual vitreous. And same thing if you manage from the pars plana, possibility that PCR extension will be less, traction will be less, and possibility of removal is more. So do this in case you are afraid of entering from pars plana. And do not do this. First, you do not do this, but best is to learn to, you have to come out of that fear that, all of us are surgeons, and insertion of trocar canal not a big job actually. So learn to use this trocar canal system because that is more safe and avoid all these complications. You see, anterior segment surgeon may get out of that tricky situation immediately, but some of these complications occur late. So that is the issue. So other thing what Dinesh was reacting to was that you can't put a phaco probe from there, even though you see all these phaco machines have a component of anterior vitrectomy, but you can't because that will not cut the vitreous properly.
Not the phaco, but we put the
Vitrector,
But
then
I'm
it's so.
saying if you have cortical material or even nucleus that's up front, have your rate slow, like 500.
Yeah.
You're going for vitreous, then you're going to 1,000, 2,000.
So what we can do is for infusion, we can put an AC maintainer. If you don't want to go from the posterior segment, you can just put an AC maintainer. So the cutter works as an aspiration and the fluid comes from the AC.
So that, I thought you were referring to the same technique. Infusion you can have from the anterior.
The advantage of using a trocar cannula over just a direct entry is the trocar cannula, when you're going in and out through the trocar, your traction on the vitreous space or the vitreous is not being pulled into the port there. If you do a direct entry with an MVR blade, each time you go in and out, there are always chances that you may be pulling the peripheral vitreous out through that. So putting a trocar, it's a very simple technique. That's what we designed through this instruction course. We want anterior segment surgeons to just forget this fear of putting the trocar. It's a very small step. I mean, you're great surgeons.
It's a small step, but if the trocar is old, you can get into big
Yeah,
trouble.
yeah. So good
It's an
trocar.
open eye. It's an open eye. So either you first suture the wound and then put the trocar, and you have to have a very sharp, fresh
Yeah.
trocar.
So
You can't use an old trocar for this kind of case.
What can be the complications?
The whole thing will come out.
Because you see,
Everything will
if
come
you
out.
have an old trocar, it will not go smoothly inside.
Even if it is fresh and
Fresh, it will go like a butter.
technique or
Huh?
not
It
used
will
to
go
it.
like a
Like a
knife
makhan,
through hot butter,
like a-
no, hot knife
Yeah.
through butter.
They can always suture the tunnel and
So you have to touch.
see,
Suture the tunnel
if you're
before-
using a old or a not a good trocar, and when you're putting too much pressure on the globe and the wound is open, everything will
You
prolapse
see, the
out.
problem is if you are exerting too much traction, the whole globe will deform, and whatever is open, contents may come out. Whether it is IOL, vitreous, whatever, it is liable to come out.
So
in an open wound.
two things what you should do is you should be away from the tunnel and away from the paracentesis. Because if you are just below the paracentesis or below the tunnel, with new trocar also you will open it and you will cause a decompression or a collapse of the globe. Once the globe collapses, you won't be able to put, you need a hard globe for insertion of trocar and cannula.
The other way of doing that is you can take a 23 gauge LVR, first make the port through that, and then pass the trocar into that.
That is what this gentleman was saying.
So you put the 23 gauge LVR, and then put the trocar.
Another suggestion,
Yeah.
put viscoelastic in the
So
anterior
then it
chamber,
will, then it's
suture
already
it. We
been,
now have
the wound
a
is.
firm eye, and maybe that would assist.
Yeah, that's what
the,
we usually
trocar.
do it. That's what we usually do it before inserting a trocar cannula.
The other thing is that if you're
Yeah,
using
yeah.
tripod, sorry.
There is a PCR in the presence of the nucleus or
Yeah.
a few pieces of
Nucleus
and
down-
we
down.
attempted to take them out first. That will also put traction on the vitreous.
That is the last step. You see, first is to remove the vitreous. Don't rush out.
Three pieces fall back.
Yeah, let them fall back. Let them fall back,
And that's
because
how the vitreous will circulate.
yeah, because unless you are well versed with the vitrectomy techniques, do not chase that fragment of nucleus. Let it fall back, because aim is to cut the vitreous and free the nucleus from all those things. Because if you try to chase back, which is the temptation that whatever is there, take it out. That is what causes the problem.
Hemlata.
Because once you take it out without doing an adequate vitrectomy, then the purpose does not get solved, and traction or pull on the vitreous is always there.
Concentrate on clearing the AC and the
Of the vitreous. The vitreous should be, cut. And if it falls back, the job becomes actually easier for the VR surgeon.
and then in that situation do we put a lens of that?
Yeah, go ahead and put the lens.
How hard the nucleus is.
Yeah, even except very hard Niagara or very dense brown, otherwise most of the phaco fragments can take care of majority of the hard nucleuses through the pars plana. We have a lot of videos to show that. Maybe somebody will show that. Even the hardest, it may take some time, but it will come out. Very, very hard, which nowadays we hardly see actually. So that is the only thing. Or sometimes if it's a nanite patient, we may not advise, but by and large we advise that go ahead and put the lens.
We often have very hard cases.
Yeah.
We do have.
So if not, allow the retina surgeon, he will also put the lens in the sulcus.
And sir, the second question is, my machine has a 20 gauge retractor. Can I do a pars plana retraction with that?
If you have,
you
why not?
can
You see,
with-
all of
But
us,
it doesn't make a difference. You can ask them to give you a 23 gauge retractor. The retractors are not different, and only the tips are different. The machine is the same. There's no difference. So you can ask them to give you a 23 gauge.
But in any case, 20 gauge will not go through the trocar.
No, you will have to make an
you
MVR
will have
port.
to make MVR opening.
One point more, if you haven't, like the case which was shown here, the IOL had been inserted when the tripod assisted. with
Second
the
patient,
IOL.
yes.
But if that has not been done, if the IOL is not there, then be careful not to put too much of tricot. You should put a very little amount of tricot, because otherwise it will go down. And then if it's a very large amount inside,
Yeah,
it can cause
tricot,
a secondary tumor.
very small amount should be put, I agree. Because
How much?
A drop.
Less than 0.1.
Sir, ideally,
0.02 or so.
0.1 or
0.02, 0.02.
0.02 ml of tricot is
Tricot,
put in
pure.
the anterior segment.
Yeah.
and normally whatsoever we have done, we do not use that preservative free tricot. We use the normal standard tricot. some companies are selling the preservative-free oro cord के
In
नाम
this
से.
situation, you
that-
need the
Yeah.
normal tripod.
Yeah.
So
Not
because in couple of webinars it is emphasized that use preservative-free. That does not work so well. That does not stain the vitreous at all.
It is very liquefied, it tends to float more into the vitreous cavity rather than getting stuck into the,
You won't see it.
yeah,
More
yeah.
difficult to see also.
No, the problem is if it goes into the mid-vitreous cavity, then you will find difficulty in removing it.
Then you
That
need
is the
vitrectomy.
problem. If you have a large rent and you have done a vitrectomy,
We should not be legally impacted.
so the ideal situation is कि you do a vitrectomy, put a lens, and then put a tricot to see any vitreous fibrils are coming into the anterior segment or not. But if you have a rent and if you do an tricot assisted vitrectomy, it will go into the mid vitreous cavity, and suddenly your glow will become white, and you won't be able to see anything in the anterior
So
segment.
retroillumination glow, everything will be white only.
You don't dilute the,
No, you don't.
Direct.
Put very little. I'm not talking of putting 0.1, we're talking of 0.02. That means 1/5 of that, just a little bit, just in the AC. You don't need too much. You just need a few crystals to visualize it.
final word on the timing of putting in the tripod, right at the
The
beginning.
ideal is what we just said. You put in the IOL, you can now clear the. But if you think that you need assistance to
लगा
figure
लेते
out where it is, you can put, but then be careful not to put too much. If you put too much, it'll go down.
So and another thing, any case that an anterior segment surgeon can consider for phacoemulsification is good enough for a VR surgeon to take out from the posterior root. So you can put IOL in those cases absolutely without any fear of.
Talking about the timing of putting in that.
So ideally, as Dr. Gupta said, do first a vitrectomy, put an IOL, stain, check whether the vitreous is completely removed.